First, I want to just thank the Petit Institute Steering Committee who every year nominate our distinguished lecturers. And we really, truly have had some amazing luminaries and thought leaders in the world that have been here to enrich us with their thoughts and their wisdom and their experiences. And this year is definitely no different. It's a great pleasure to introduce our 2017 Petit Institute Distinguished Lecturer, Dr. Michael Debaun. Michael told me to keep this short. He said, just say I'm the husband of one and father of two. So we're going to add a little bit onto that. I immediately had great respect for Michael because he is a true clinician scientist, and I've always really respected someone who can do both those things. One of the rare individuals whose work has not only led to significant advances in science and understanding the etiology of diseases, but also fundamental improvements in how patients are cared for. He's a professor of pediatrics and medicine and vice chair of clinical research at Vanderbilt University School of Medicine, where he holds an endowed chair in pediatrics. He's also founding director of the Vanderbilt Meharry Center for the Excellence in Sickle Cell Disease. He graduated magna cum laude from Howard University and then moved on to Stanford Medical School, where he received his medical doctorate as well as a master's in health services research, and later a Master of Public Health from Johns Hopkins School of Public Health. Since then, he's gone on to become an internationally recognized physician scientist who has not only done research but also advocacy, and this has resulted in fundamental advances in sickle cell disease. In fact, he was the primary physician author of the Sickle Cell Treatment Act that was signed by President Bush, the second President Bush, into law on October 22nd, 2004. So I'm gonna skip over some of the details on his research because, as he said, the talk can stand for itself. He certainly received a lot of awards, and I won't go through all of those, but just to mention a couple, he received the 2014 Ernest Buechler Prize from the American Society of Hematology. He's also been elected to both the Association of American Physicians and the National Academy of Medicine. So please join me in giving a warm IBB welcome to Dr. Michael Debaun.
Thanks, Bob. Well, that introduction was so good, I started to applaud for myself. So this is a real honor to be here, quite frankly. I had some degree of trepidation. Well, why would a school of engineering ask a physician to come and talk to people who know more about differential equations than I forgot, ever? And, but it's a real privilege after meeting Bob Nerum and really just sitting for a moment in this atrium and understanding how this building was built, the inspiration and the sense of community that Bob put together to have really a sense of scholarly activity as well as community spirit about discovery. And I really think that, quite frankly, he gets the honor for the applause. So I would want to do that. So yeah, I mean, I'm in awe, quite frankly. What should I talk about? Well, traditionally when I give talks, it's almost always data-driven, and I am compelled to tell you how I started the project and give you some data about the middle of the project and give you the end. But I want to try to shift your paradigm for a minute and have you think about this concept that if we're going to support others in scholarly activity, that our strategy should be one in which we are missionary workers. We go to a place, we do something in that location, we leave. And quite frankly, that model, from my opinion, doesn't work very well. And really what we should be thinking about is an intersection in knowledge between not only providing support, but also advancing the care. And then something that I didn't mention in the slides, but I will mention here, this perception that knowledge is one way, that you go from a high-income country to a low-income country, and that it can't be the other way, that we can learn from people who are in low resource environments, I think is a misperception of how knowledge should be transferred. So I just have a few slides to discuss the basics of sickle cell disease. I'll talk to you about the original patient that got me interested in this challenge, problem to try to solve in 1991 when I was a hematology oncology fellow. And then I'll talk a little bit about my road trip to northern Nigeria, the trial that came out of that road trip, the more definitive phase 3 trial that's still in progress, and then a new problem that I hope that the engineers here at Georgia can solve, or at least help me solve, that will hopefully save lives. So this is a very traditional slide that you would see in medical school. It's a picture of sickle cells and red blood cells that are seen under the microscope. And the typical red blood cell is round and discoid shape, and you can see these cells that look like sickles. They're fragile, they have a decreased survival of 15 to 20 days versus 120 days. They're rigid and inflexible, and they cause a chronic hemolysis with laboratory abnormalities. As a result of some pioneering work that's been done over 30 plus years, newborn screening is now mandatory in the United States. Every state in the union provides newborn screening for children with sickles, for every newborn. And as a result of this effort, there's a significant reduction in death and illness in infants with sickle cell disease. So this is actually one of my favorite slides to show. It turns out that if you are interested in public health, you would spend a disproportionate amount of your resources on the most common diseases in the country identified in newborn screening. It turns out that sickle cell disease occurs 1 in 2,400 newborns, regardless of race. Actually, in African Americans, is 1 in 400. Now, you compare that to congenital hypothyroidism, which is 1 in 3,000, cystic fibrosis, which is 1 in 3,000, and variants of PKU, which is 1 in 13,000. So despite the common prevalence of this rare disease when compared to the other disease, the resource allocation is actually nowhere near reflective of the patients born with this disease in the United States. So this is a quote taken from William Osler. It describes the concept of laboratories and clinics, and it states clinics or laboratories of the highest order. So I want to flash back to 1991. Some of you may not even have been born in 1991, but I was definitely alive and working hard. And then I got a phone call. I won't draw this drama out. It was actually my mother. I was a hematology oncology fellow. She was a Montessori teacher for the only Montessori school, public school in Missouri. And she had a 10-year-old who was a student. And she was concerned that this student was unable to remember skills that she had mastered 3 months ago. And I still remember today. So, Mom, tell me a little bit more about this student. And so she would go on and describe that she completely lost her skill set. I said, well, is she walking at gym? Because at that time, the third grade teachers would go out for gym class and go out for recess. No, she's fine. She's having a good time. She's not having any challenges walking up steps. And I said, well, I'm not really sure. So I was my mother's son. So she asked me these questions. And these were the questions that have essentially been the cornerstone of what I have focused on since 1991. The first one was, what's wrong with Michelle? And then the next was, what can you do to treat her? And then for a teacher, it was all about, what can I do to help her learn? And so fortuitously for me, it turns out that she was the patient, the student was in a natural history study sponsored by the NIH. And in 1989, the MRI of her head is seen here on the left. And then subsequently, she had an MRI, again, as part of this natural history study. And what you see is on the right. Now, the official report was no change. But clearly, I had the benefit of my mother asking me questions at every family get-together. What's wrong with my student? So as we have learned often, I'm sure this is the case in engineering where you check the empiric data yourself. And so despite the radiology report saying no change, it doesn't take a neuroradiologist to see that in fact where the white arrows are new lesions. Now this is about the time that new technology had been introduced. And so there was a skepticism among our neuroradiology colleagues, almost all of which were adult radiologists. There really weren't any pediatric neuroradiologists who were board certified at that time, and at least at our institution. And they basically called this artifact. And if you go back through these MRIs that were done in the early 90s, the description is actually unidentified bright objects. That's actually a term that they use, or requires clinical correlation of unclear significance. But because of this patient and belief that she did have something that was cognitively in despair, cognitively disruptive, I pursued a series of studies that I'll just briefly go over now. One of them is this concept of how prevalent is a silent stroke in children and adults with sickle cell anemia. And what you have here is the mean age on the x-axis and the prevalence of silent cerebral infarcts on the y-axis. And you have these various studies that were done across the globe where they brought children and adults into an MRI scanner who had no prior symptoms or knowledge of having a focal neurological deficit indicating a stroke, and getting an MRI to determine if they've actually had an infarct. And these, every point represents actually different studies, and this was plotted out quite nicely. I didn't make this plot up. The last circle, in fact, is from our center at Vanderbilt. When I moved from Washington University to Vanderbilt in 2010, the adult hematologist was, who's a friend, and I'll mention him in a second, was less than interested in getting surveillance MRIs. But as we pointed out, if you look at by 18 years of age, 39% of the children, adolescents, before they finish high school will have a presence of a silent stroke. There are very few conditions in medicine where the pretest probability is almost 40%. So why would you not want to know if the adult you're taking care of has had a silent infarct? And so with the data that we had previously published, we were able to go ahead and continue to do surveillance MRIs in the adults, and this was the result of the publication showing that over half of the adults by 35 years, approximately 32 years of age, will have silent cerebral infarcts. So this is a complicated slide, but I want to spend a few minutes describing the impact here. So so when you find these lesions in the brain, it took me about a decade of meticulous clinical research of first describing where the location of the infarcts were, whether the infarcts were associated with specific neurocognitive domains, whether the infarcts were associated with academic difficulty. Because at the end of the day, if I tell a parent your child has lost 5 IQ points, that doesn't necessarily translate into anything for the average parent. But what it does do is translate into children who've had silent strokes actually have a higher rate of grade failure. So we went through all of that to eventually get to a point where over a course of multiple years, from 96 to 2011, there were roughly 10 studies that had looked at the impact of the presence of a silent cerebral infarct on full-scale IQ compared to the impact of full-scale of the MRI when there was no infarct on your full-scale IQ. And essentially in this forest plot here, let's see here, let's see if this works. Is this? Well, I'm not sure I'm showing this here. Oh, here we go. So in this forest plot, this is for the students who don't normally see forest plots. I can just give you the bottom line. Typically, you want to look at the diamond at the end, which is a summary effect, and it's based on which assumptions you use to model the pooled analysis, whether you use the random or fixed effect. But regardless, you can see that on average, you lose about 5 IQ points for children who've had the presence of a silent infarct. So I would be willing to bet that there's not a single parent in this room that would argue to say that that's not a consequential loss in their child's full-scale IQ. Typically for lead poisoning, something that pediatricians screen for, particularly in urban settings, you're screening for a effective lead poisoning of 2 to 3 IQ points, maybe 4, but 5 IQ points is a dramatic shift in the curve of this population. So I was part of a larger group, cooperative study sponsored by the NIH, and in this study we were able to do surveillance MRIs. The young student that I mentioned before was part of this larger NIH study, which was non-hypothesis driven, wanting to characterize the natural history of the disease, and thank goodness for non-hypothesis driven work to characterize a rare disease, because you can see here on the x-axis is the follow-up time in 248 patients. On the y-axis is the cumulative stroke risk, and you can see that of the patients who had silent strokes during their first MRI, they had an ongoing progressive risk of new lesions in their brain or strokes when compared to patients who had normal MRIs. So I've just summarized, basically a decade worth of work in about 7 slides. But nevertheless, we were able to show that silent strokes are prevalent. They are associated with a 5 IQ point drop, and they're progressive in nature. So when you have these constellation of findings, common, associated with a morbidity, and progressive in nature, then the next obvious step is to go back to the question that my mom had asked me, which was, what can I do to prevent this from occurring? So there's a 2-step process, as there typically is in clinical patient-oriented research or clinical research. The first is you have a feasibility trial. So I was funded by the Doris Duke Charitable Foundation in '99, and we set up a feasibility trial to see if A, families would be willing to accept transfusions for children who had silent strokes, and B, how long they would be followed adhering to monthly transfusions. And the results were supportive, and we used that data to ultimately get the more definitive trial funded by NINDS from 2003 to 2013. The primary hypothesis was that prophylactic blood transfusion therapy in children with silent cerebral infarcts will result in at least an 86% relative risk reduction in the proportion of patients with clinically evident strokes or newer progressive strokes. There were 29 sites that participated, included sites in Canada, UK, and France. We had a statistical data coordinating center, an imaging center, and we actually have a biorepository where we have immortalized cell lines for ongoing supply of DNA. And the trial actually took 10 years to complete. So this is the second 10 years of my life. And it was published in August of 2014 with the New England Journal of Medicine. I won't bore you with all of the details, but I do want to take a moment to tell you about the patients that participated in this trial. When you looked at the majority of the patients from the United States, the yearly income per capita was $8,500. So that means for a family of 3, they were getting by on less than $26,000 a year. This is what we asked their families to do. They had to come in for 3 years for monthly transfusions. They had to have 3 MRIs of the brain. I don't know if anybody's ever had an MRI. They're loud, they're obnoxious. Many adults can't go through them. But in order to complete this trial, you had to have 3 MRIs. You had to have 4 neurology evaluations by a pediatric neurologist. You had to have 3 cognitive test sessions. You had to have 2 quality of life sessions. So with all of that, we had 86% completed this trial. So this, so I'm always marveled, with the misinformation about what Black patients will do or won't do in terms of participating in clinical trials. You could not have asked for a more onerous trial for a population who is more economically disadvantaged. And yet, we had 86% complete all of this. So, and then the rest, we had some who had partial completion and some who had no exit data. So what about the results? I'm going to summarize it in 2 slides. So first, the risk of an infarct recurrence. So you've had a silent stroke, and the question is, well, what happens again? Do you have another silent stroke or an avert stroke? So that's an infarct recurrence. And so the risk of infarct recurrence, or TIA, which is probably, in this setting, evidence of ischemic injury to the brain, was 5.6 events per 100 patient years. When we use blood transfusion monthly, the risk of an infarct recurrence when treated with regular blood transfusion therapy for silent cerebral infarct were 2 events per 100 patient years. Now, there's a nuance for the hematologists in the room I just want to mention. We had randomized roughly 99 patients in each group, roughly. And it turns out that of the 99 patients who were supposed to be transfused, 9 did not receive any transfusions at all beyond 6 months. So we were obligated to still use the intention to treat, which is a much more conservative strategy than saying, okay, we're going to count those 9 patients who never received transfusions as a non-transfused group, even though they were randomly allocated to the transfusion arm. But nevertheless, we stuck by the book because we knew this trial would come under much scrutiny, and despite all of that, we still found favorable results showing evidence to support our hypothesis. So the second challenge that we have is blood monthly is an onerous, very difficult challenge for families. They typically come in the day before to get the type and cross, and then they spend 3 to 4 hours to be transfused the following day. So often it's 2 visits a year, a month, sometimes even more. And so some of my colleagues will say, and I understand their hesitation, well, why would we want to transfuse a child, give them this burden to protect their brain? And so I struggled with this discussion because I know if it was my child's brain, we would be there every week, not let alone every other month, every other 4 weeks, every 4 weeks. We would be there often as they requested. And so what I ended up doing was trying to identify an anchor that would allow for judgment to be commensurate with what society has said is the appropriate prevention for a stroke. And so you may not know, but it turns out if you have this condition called atrial fibrillation, standard care in the world is to give a oral anticoagulant. And what we're trying to do is prevent those patients from having a stroke. And so for those patients, the event rate is 4.4 events per 100 patient years. So often graphs speak louder than words, and so I just wanted to reemphasize this point. If you had a hypothetical cohort of 1,000 children with sickle cell anemia and silent cerebral infarcts, followed for 5 years, with transfusions or no transfusions, what you would expect in the transfused group is that out of these 1,000 patients, 95 over the course of 5 years will have had progressive injury to their brain. And of the children who were not transfused, 214 would have had new lesions in their brain. If you compare that to adults who are not with atrial fibrillation, who are not treated, which all of us would consider below standard of care, approximately 200 would have had a stroke. So let's go to this third set of questions that my mom peppered me with. And so what can I do to help teach Michelle? So this is a long line of investigation, and I'm just going to give you some highlights. A former mentee of mine, who, Dr. King, who's board-certified pediatric hematologist, oncologist, has gone on to get her PhD in education, and this is her major focus now, is how to improve the lives of students with sickle cell disease who've had infarcts. So we set up a pilot randomized education rehab trial and demonstrated that it is feasible in children with sickle cell and strokes. We showed that the concept of having a disease in isolation of the home environment is is a misnomer, that poverty, and as I mentioned earlier, a disproportionate number of the children that we take care of are poor. But the parent education, as indicated by graduation, was associated with a 6 IQ difference, where the presence of a silent cerebral infarct was 5 IQ difference. And the household income had a greater influence on grade failure than the presence of a silent cerebral infarct. So, so that takes me to like 2009, okay? And so the little kids, the babies that I'd been taking care of grew up. They now become adults, and I have to go through this uncomfortable transition of taking care of an adolescent for 20 years and then handing them over to an adult provider who may see things differently than I do. And so I was actually in Atlanta at the CDC on sabbatical, and I received an email from one of my patients who wanted to contact me because I wasn't in St. Louis. And this is a story that I'll tell in a second, but before I tell the story, I want to give you the background of this picture. This is a picture written by drawn by an individual who has sickle cell disease, and is called 10 Redefined. And the story that he gave at a national meeting about how he came about this picture was that the common language in a hospital when you're in pain is, describe to me how bad your pain is, and then based on how bad you say your pain is, I will give you your pain medication. You can see that this can be quite an adversarial interaction where a healthcare provider may not believe you're in pain. And so in his description that he was 10, the healthcare provider said, well, I don't believe you in 10, so I'm not going to give you your pain meds. And so he appropriately drew a picture to define this moment and called this 10 Redefined. Now, for those who think that this is an isolated incident, it's not. Currently, in many major medical centers, adults with sickle cell disease who are in excruciating pain sit in the emergency room for 6-8 hours. So it's a problem that has not been met with much acceptance within our system. So this is the email that my now 22-year-old sent me. It says, I know it's been a long overdue since we've last talked, but I'm hoping to break the silence today. I wanted to ask you if you knew of any adult hematologist who provides good care. Since I've been here, despite doing everything that I've been told to do, taking hydroxyurea and folic acid the right way, even taking OxyContin and oxycodone around the clock, these are very powerful pain medications, I've still been in constant pain. My hemoglobin will not stay up past 3.7, sometimes lower, for more than a week at a time, despite receiving constant blood transfusions and a series of shots every 3 weeks. I feel as though the longer I stay here, the worse my health becomes. So I ended up having to come to grips with, it's good to be a NIH-funded investigator. It's good to lead an international trial. I mean, you get a lot of accolades for that. But at the end of the day, when I go back to see my patients, they don't really care about that. I mean, quite frankly, it doesn't matter to them at all. In fact, when I went to WashU to Vanderbilt, one of the first patients I saw, the mother said, you can't lay a hand on my child till you tell me what you know about sickle cell disease. So really, from a very practical point of view, it's nice to get these accolades, but when I'm in the room with a family, they just want me to take care of their child, and the older adult wants me to take care of their younger adult child. So I kind of chucked it all in at WashU and said, I'm going to try something different. I wanted to create a medical home for children and adults who could receive medical care across the life spectrum with the same philosophy of care across the life spectrum. I thought it was unfair for the pediatric hematologist to have one style of care and then for them to immediately go to another provider who has a completely different style of care. Something as different as what would your pain medication be? Or something as different as how we're going to manage you at home versus how we're going to manage you in the hospital. So Vanderbilt was willing to take a gamble on me, and I just have some very simple requests. But one was that we would take the medical care out of the academic center, these monstrosities which, eight parking garages surrounded by the hospital is very difficult to navigate. A cup of coffee costs $3, lunch costs $10 for two, and go into the neighborhood in which many of our families were located. So we created this mission to provide in a medical home setting the best available medical care, educational support, and research for all the children and adults and their families whose lives are affected by sickle cell disease. So what does this mean? We had evening clinic weekly because, as I've already told you, many of my mothers are working poor and fathers, and they don't get off work till 4 or 5 o'clock. So I needed to have clinic that was available in the evening. I needed to have clinic on Saturdays. Initially it was twice a month. We reduced it to once a month, again, for the same reasons. I wanted a pulmonary function lab in the clinic because 25% of my children that I take care of have asthma. And I wanted a psychologist that was going to be available. Now, when I came in, made those, they gave me carte blanche to create a program the way I wanted to. Within 6 months, the prior sickle cell team left. And which was, it's always a little daunting to lead a team and you be the only member on the team. So the social worker left, the other hematologist left, and the nurse case manager left. But that was okay because I was able to hire people who I could handpick, who were willing to give up their Saturdays to come see these families and to put their needs second to the needs of our families that we were providing medical care for. So it's worked out quite well, but I want to drill down on how we handle this academic challenge for our students with sickle cell disease. So, I am probably more like a principal than I am like a doctor, because when I see my students in the office, I will ask them how they're doing. And automatically, now after 7 years, they know I'm not talking about their sickle cell disease, but I'm talking about their academic performance. And so eventually I move on to the sickle cell disease, but I would be willing to bet that one's quality of life is heavily related to their ability to be independently supportive, and in this era, that's highly correlated with the ability to finish high school and to get some type of vocational training or college education. And so this is the story of a young boy that I take care of, and he was 9 years old at the time. We do surveillance MRIs of all of our children with sickle cell disease for the reasons I've already stated. His grades range from A's to D's. And I'm pretty direct, and so I said, "So tell me why you getting D's?" And he just basically started to cry and said, "I'm too slow." So at that time, there were no academic accommodations that were made for this child. Mom was unfamiliar with how to navigate the system. We had the benefit of a psychologist on the team. We performed these standard evaluations. I want to point out that the full-scale IQ was 100, which is exactly what you would expect. And yet, despite this child's IQ being 100, processing speed was 5%. And one of the tests that we asked him to address was his ability to copy figures. And it really doesn't take educational specialists to see that he has some challenges in recopying these figures. So what happened shortly after that? We provided a written report to the family and the school. Our social worker attended a meeting for his individual educational plan. He was identified as having a written language disability. There was classroom accommodations. In 2014, he got mostly A's and B's. He scored in the proficient range on all standardized tests, math and language skills. He's a much more confident young man now that I see him in 2016, and actually has aspirations to go on to college. So this is hard to capture in a manuscript. but it makes all the difference to this parent and all the difference to me. So when I was at Vanderbilt, after being there for about 9 months, Adetola, who's a friend, close friend of mine, although he wasn't a friend at the time when he said it, said, you think you are so good at what you do. How can you be good at what you do and not have any presence in Nigeria? And you've completely ignored the problem of sickle cell disease in Nigeria. So what did Adetola know that I had a passing, not even a passing knowledge? I just knew there was a lot of sickle cell in sub-Saharan Africa, but I didn't know where it was. So this is a cartogram of the estimated number of newborns with sickle cell anemia based on demographics, mortality, and interventions. And what you see here is the obvious large, darker space is Nigeria. And it turns out that Nigeria has 150,000 children born with sickle cell disease a year. Ghana has 14,000, and the US has around 2,400. So, you know how this academic thing, you've seen this dog and pony show, you get invited to come places and you give talks. So I had a buddy, still have a buddy, named Baba, and he said, look, I want to bring you to Nigeria. I said, it's strange that you should ask me to come to Nigeria. Somebody just challenged me, and I had been trying to get there for some time. So Baba had me on this road show, on a road trip we flew into Abuja, and then we had to go all the way up to Katsina, just right below Niger. And so what Baba didn't tell me, and I wasn't worldly enough to know, was that he was going to have me stop like every 3 hours and give a talk. So I did. And what he also didn't tell me was, because I kept asking for the agenda, he says, it'll be fine, it'll be fine. So we had to have an escorted driver. And we were guests of the governor and his private security force. And it's actually my daughter with me. And so I had said to him, look, I'll go on this trip and you can do with me as you will. I'll talk as long as you want me to. But at the end of the trip, I want to have a retreat for girls or a camp for girls with sickle cell disease, because I know that'll be one thing I will remember. It'll be something they may remember, and my wife and my daughter will enjoy it, and they have been doing this while we were in St. Louis for about 9 years. So my wife, daughter, his wife and daughter went on this road trip with us. And so since I was working the whole time, this weekend was their turn to work. And so they put together this camp score, and you can see introduction, breakfast, games, relax, pain scale, crafts. They had a skit practice, because they had a skit at the end of this interaction. And at some other point I can tell you about the skit. It was actually very fascinating. It taught me a lot, even today, that I still use in my care for these patients in this region. Lunch, we had a dress rehearsal. They had a dress rehearsal for the skit, certificates, presentation, and a dinner. And on nowhere do you see that there's any involvement of an MD. It's all about the girls and the women that are supporting this activity. So this is a picture of two little girls that participated in the activity. But what I didn't know and didn't anticipate was that the parents had traveled all over the state to come to this activity, and they weren't leaving. So on Saturday, they were like stuck to the girls, and you can imagine that there was no free discussion with the girls, there was no fun, because the parents were in their space. So my wife decided on the one day that I thought I was off, I needed to come in and entertain the parents. So I had the parents of these 42 girls on one room while the girls were in another room. And in the course of, it is totally impromptu. What do you do with 42 sets of parents all day? So I ended up teaching the parents like I would teach any parent that was in my clinic. And so we started to go over little things, and here I am teaching the nurses and the parents how to feel for the spleen. Saying the spleen's on the same side of the heart, is in that right underneath there is a rib cage, and I point out the rib cage, and you you want to feel for the spleen, and this is a very standard approach that all of us undertake to educate our families about complication of this disease. And then in the course of this 6-hour educational session, one of the parents described their daughter, and they described specifically that their daughter could no longer walk with a normal gait. She couldn't hold a pencil with her hand. She was doing poorly in the classroom setting. And so I said, well, then unfortunately, I believe your daughter has had a stroke. And so no one in the room knew what a stroke was. They never knew that a child could have a stroke. So this was kind of a moment of clarity. And so, you know, my whole thing for this day was this is all about the girls, it's not about the parents. But the parents were kind of a tug of war of, we want to see what a stroke looks like, go get this girl. And you know, I'm pretty stubborn, I was pretty adamant, no, this is not the reason I'm here. I'm not here to be a doctor, I'm here to educate you, and you can see your doctor about the stroke. But they wouldn't take no for an answer, and obviously, she ended up in the room with the parents. So this is Baba interviewing the mother and the little girl, and she had a hemiparesis on the right side, and the mother stopped her from going to school because she felt that she was cognitively impaired and therefore wasn't worthy of attending school. So we had some discussions about that, and you know, I was pretty adamant that she should have the privilege to go to school and that she would have skill sets that could be learned. Now, when you look at the challenge, 6 of the 42 girls in that retreat camp had a stroke. Because once we identified that little girl with a stroke, there were 5 others who were at that camp who had a stroke. So of course, every mother seeing this daughter saw their daughter and said, oh no, you need to examine my daughter. So it turned out to be an impromptu stroke clinic. And so when you go back and you look at the public health data, about 10% of the children before screening for stroke and treatment with blood transfusion in the United States develops a stroke. And so if you take a birth cohort of 150,000 children, then that would mean in the country of Nigeria, there would be 15,000 children, if they lived to 15, that would have a stroke. And if you looked at children with silent strokes, it's 3 times that. So I have to tell you that that dinner was solemn because we were sad. I mean, you know, we came there to do something fun, and we found a problem that seemed to be challenging and overwhelming. So we do what we've learned to do as physicians and scientists and all this training that Bob described. And we sat down and we tried to come up with a strategy to address this problem. And it wasn't easy, right? Because you could say, well, you have these children who've had a stroke. Do you go after a secondary stroke prevention? You have children who are at risk for a stroke, but at the time, the only treatment for preventing a stroke was transfusions. And I'll give you a few slides about this. Is there a way that we can predict who is going to have a stroke? And the answer is yes. And this is done by a guy named Bob Adams at the Medical College of Georgia. Really insightful and transformative in the care of this population. So Bob showed that if you use a probe, you could look at the velocity of the blood flow through the middle cerebral artery, and you could measure the velocity above a certain level would be predictive of having a stroke. And I just want to go over this briefly. So typically, as you can see here, the probe is put up to the MCA. You get a velocity, which is highlighted there in the red, and the vessel is patent, and the velocity is typically low. As the vessel becomes slightly stenotic, the velocity will go up a bit, and when the vessel is more stenotic, you'll actually have levels that are very high. And this is what it typically looks like for an imaging TCD. Again, the mean TCD in this particular case is 101, which is low, but he was able to show quite nicely that if you stratified the velocity of the patient according to three groups, less than 170, 170 to 199, and greater than 200, that the individuals who were most likely to have a stroke were those who had velocities greater than 200. And what you see here is a Kaplan-Meier plot where time is on the x-axis and the probability of remaining stroke-free is on the y-axis. And you actually don't need a statistician to see that if your TCD velocity is over 200, you have a problem. So, so as a result of that really transformative effort of research by Bob Adams, we now have a primary prevention of stroke for children with sickle cell anemia, which has dropped the rate of stroke in major academic centers that are able to apply this technology to their patients on a routine basis. It's dropped the prevalence by logfold. Now it can be as low as 1% as opposed to 10%. So the typical paradigm, you have a screening TCD typically annually. You measure the transcranial velocity in the middle cerebral artery and the terminal portion of the internal carotid. You stratify the patients above 200 or below 200. If they're above 200, you typically get transfusions. Up until recently, it was monthly for an indefinite period of time. However, at the time that we were in Nigeria, transfusions were just not, and still is not an option. There's an inadequate blood supply, there's a cost of monthly transfusions, the transfusions are unsafe, and there's a high probability of blood-borne infections. So the only alternative is hydroxyurea. It was FDA approved for sickle cell disease in the United States. It increases the total hemoglobin, which we know decreases the velocity that goes through the vessel. It significantly decreases the TCD in children with sickle cell disease and in abnormal TCD values. There's some efficacy in secondary stroke prevention, and it's very cost effective and practical. So we put together a trial. I'm a dreamer, and so we made this logo well before we got funded, and then we got funded. So this was a feasibility trial for primary stroke prevention in children with sickle cell anemia in Kano, Nigeria. We had 3 measures of acceptability. The first was, of the families that we approached, how many would agree to be screened to be in this trial? Because we had to do a transcranial Doppler. The second was, of the families who were eligible, how many agreed to participate in the trial? And 92%. Now, we asked these families to come back monthly. There were no missed visits for over 2.5 years. This is rural, urban Nigeria. In terms of laboratory values, we saw toxicity. We saw no laboratory evidence of severe myelosuppression or that's a low white count or toxicity in the group using a fixed dose of hydroxyurea of 20 milligrams per kilogram per day. And then in terms of adverse events, namely death, we were very concerned about death, which was the main reason that we started this trial in children 5 years of age or older, because the mortality rate in children with sickle cell anemia less than 5 years is very high, estimated in some environments to be as high as 70%. So we started with children above 5, and there were 2 deaths in the treatment group and 10 deaths in the comparison group. And when you looked at the significance between the two, there was no difference. So from that point of view, very appealing to move forward. Although this was an intermediate outcome, the definitive outcome is whether or not we prevented children to have a stroke. These are all children who were started on hydroxyurea at fixed dose of 20 milligrams per kilogram per day. And there was an 85% reduction in TCD velocity after starting the hydroxyurea therapy. Again, very supportive. So we were able to leverage this data, and our main support for our preliminary data was that first, this literally was the first randomized controlled trial for sickle cell disease in all of Africa, sponsored by the NIH. And so we felt that we had strong evidence for success based on the acceptability and potential safety of a moderate dose of hydroxyurea, and that the initial pilot data was supportive of using hydroxyurea for primary stroke prevention. And so this is our new logo. Stroke prevention in Nigeria. It's multiple PI. Najiba is a mentee of mine. It's got our MPH at Vanderbilt and is now a full-fledged leader of this trial. And Mukhtar is actually a colleague, associate professor at Vanderbilt, who's from this city, Kano, Nigeria. And our primary hypothesis was that there would be a 66% relative risk reduction in primary stroke prevention with sickle cell anemia with elevated TCD. It's a very large trial. We're screening over 2,000 children. 220 will be randomly allocated. It will be fixed dose of 20 mg per kg versus 10. My colleagues in the room may say, well, why are you using 20 versus 10 as opposed to 20 versus maximum tolerated dose? A CBC in this region costs $5, and most families can't afford it. And so if the effect of decreasing the TCD can be seen in a lower dose that doesn't cause any toxicity, then we may be able to have a bigger impact. And half the dose treats twice as many children for the same cost. So we designed the hypothesis so regardless of the result, we'll get an outcome that will help, that will change the field. And time will tell. We'll finish in 2021, July. So I have my last 2 slides, and I want to end with this. So what does sickle cell look like in a country that has 150,000 children? So this is a picture of Murtala Muhammad Hospital. This is the hospital that is one of the participating sites in Kano. They see over 100 children with sickle cell disease a day, 5 days a week. They max out at 200. At 200, they tell the families you have to go home because we can't service all 200 children today. The majority of children are provided medical care by nurses and community health workers. On Wednesdays, only Wednesdays, the child is seen by a physician, and usually that's for new diagnosis. They have over 10,000 children registered. And so when we expanded the feasibility trial to this setting, we saw some things that we had not seen before. And so specifically, we saw that we had 5% of the children had hemoglobins less than 6 grams per deciliter. So in a sickle cell population in the United States, we have the data from this large trial. Less than 0.1% of all children in high-income countries had hemoglobin levels less than 6%. Now, why is that important? It turns out that hemoglobin levels less than 6, your normal hemoglobin for most of us is between 12 and 14. It's a risk factor for early death. And their workflow for how they decided to let a family know if the hemoglobin was less than 6 was not time sensitive. Lab would be drawn on Monday, we'd call the family back on Wednesday and tell them to come back in. And because this is a formal trial, a child died in the interim. So as many of my colleagues know, point of care testing has become the new wave in biomedical engineering. And so we looked for machines that would advertise that they could measure the hemoglobin at the point of contact. But the challenge is the companies who developed these machines were going where the money was, and that's you have to have a normal hemoglobin, not an abnormal hemoglobin. And obviously, children with sickle cell anemia have abnormal hemoglobins. So despite talking to the scientific rep for the company, guaranteeing me that they could still pick up hemoglobin S, we went out and bought these machines and they didn't work. So my challenge to the Georgia Tech community is help me figure out a way to get a machine that will give me instantaneous hemoglobin readouts for children with hemoglobin SS. It won't just help these children in Nigeria, it'll help the same group of children in India, where 40,000 children a year are born, and as well as the children in the United States who live in rural America. So, the team back home, with a few of the people from team members from Ghana and Nigeria in this picture, thank you very much.
Thank you, Michael. That was an amazing story. Stories. We have some time for some questions from the audience.
Very nice talk. My question relates to the silent strokes of the infarcts you showed on the images. So I was wondering whether, if you look at a number of images, is there a specific pattern? At least in the image you showed there was some pattern, or it's a random spots that you see them.
Yes, oh, that's a great question. So I just want to, this is a great question, particularly for the engineering students. So when I started this in '91, and I worked with a neuroradiologist since the mid-'90s. So in this large trial where we had over 1,000 images, I have a colleague, he's still my colleague, that agreed to map out the region of the brain for every one of these lesions so that we could have a density map of where they occurred. And so, we've both been busy. So about 3 years ago, I asked him I said, hey, I'm ready to analyze this data that you painstakingly mapped out on all of these images. And he said, Mike, I don't have the time, but I have something better for you. So it turns out that the folks at Mallinckrodt have created the workflow to do a heat density mapping of all of the lesions. And if I had the time, I'd show you, but it's in the border zone region between the ACA, MCA, and PCA. So, and it maps out beautifully. And what we want to do is publish this so that it will help the clinician say, this is the zone that we expect for silent cerebral infarct to occur. If you see these white lesions outside of this zone, think of an alternative diagnosis. Obviously, we're not going to make the diagnosis, but we want to give them a probability of where the lesions are based on this location, probability of the lesion and a silent infarct. So stay tuned. We're working on the product. The images are beautiful.
Thank you.
Questions? Yeah, thank you again for this work. So I guess one of my questions is, are there any cultural differences with beliefs about children that have had strokes that would need to be overcome, or were there other things that the parents still get? My child has had a stroke, that would be a complicating factor in dealing with Western medicine.
Yeah, so, every culture has its subcultures. And then within every subculture, there are fractions of those cultures. And what I can say is that if I just look at the data, none of those patients, none of the parents missed a single appointment for their child to come in who's receiving this medication. And I am of the belief that I know. I mean, one of these families lives 3 hours away and had to go through unbelievable driving situations to get to the clinic monthly. And that's with the roadblocks and the security blocks and the risk of kidnapping and the risk of Boko Haram and the like. And so all the objective evidence I have is they care about their children just as much as my parents care about theirs and just as much as I care about mine. So I think that when you're able to explain, and we spend an inordinate amount of time. I mean, we spent a boatload of time explaining what the drug is. We gave them a handbook in Hausa and a handbook in English. We made a video what a stroke is. I mean, and the people who are people who they know are the ones that we educated for a full year. So is there people telling them what the problem is? I get all the credit, but I haven't taken care of a single patient in Nigeria. So I would say all the objective evidence is the significance of a stroke in the lives of a child in Nigeria is the same significance of a stroke in the lives of our own children.
Thank you so much. That was an extremely inspiring talk for me. I want to ask you about the transfusion therapy. I had a conversation with John Roback over at the Transfusion Medicine Center here at Emory and Choa, and he gave me the impression that the age of some of the lots that sickle cell patients will receive is somewhat older for details that he gave me that I didn't quite appreciate. But the question I have is, in your trial, is there any, is that a factor? Is storage lesion in any way a potential problem for transfusion medicine in sickle patients and any other kind?
So there's two real quick answers. In the SIT trial, I wasn't clairvoyant enough to ask for the age of the transfusion units. Because we had 90 patients transfused for 36 months. So that's a lot of transfusions. But I just wasn't insightful enough to say, oh, age of the unit may have an impact of who recurred and who didn't. The second is that I think uniformly in most centers that I'm aware of, we would prefer to get the young cells. And we preferentially receive the young cells. In St. Louis, where we set up a directed donor program, average age of the cells were usually 7 to 9 days, 7 to 9 days. And the obvious reason is if you infuse young cells, then they last longer. And I was mostly concerned about, well, if I can take every 4-week interval for a mother and a child to every 6-week interval, then that's saving that family an extra couple of trips per year and many trips over a course of a decade, because many of the children were transfused indefinitely.
Michael, you've been really successful getting NIH funding for your clinical trials, and from your talk I gleaned 2 really important factors. One is obviously your passion for your patients. The other is having a really good logo as you're putting it for your grant proposal. But I imagine there's some other things. Could you give us some advice for those that are trying to get clinical trials funded?
Yeah, so I would be remiss if I didn't say that that my wife is my best friend. She's been with me since my days at Howard. And so really I get all the credit, but she's a silent partner. And I do a lot of work at home, and she eavesdrops, or maybe not eavesdrops, but here's the conversation. And then, we get into the discussion about unsolicited advice. But her unsolicited advice has been more valuable to me than any of the solicited advice that I've gotten from NIH study sections. Because she comes from a totally different point of view. And I'll just give you one nugget, and then we can close on this. So the biggest challenge in capacity building in Nigeria for primary stroke prevention is the machine costs 15 grand. But we have a grant to take care of that, and we have capacity building in the grant. But then I didn't have any of the radiologists who knew how to do the TCD. And so originally I was talking to Bob Adams, and I was trying to set up workshops and bringing them to Georgia for his TCD workshops, or bringing them to London, but that was costing an arm and a leg. And so I was bemoaning the fact that I didn't have any way to do that. And she says, why don't you just teach Nigerians how to do it? And so that became an obvious solution. And now we have a radiologist who probably has trained more individuals with doing TCD than anyone other than Bob Adams. And so we have built our own system in-house that is now expanding to other sites within this region. And so I would say keep an open mind and solicit advice from people who are your best friends. They'll be the most honest.
All right, well, we want to